Now, the easiest to understand of all of the leukemias for people ends up being plasma cell disorders. And the reason that it's plasma cell disorders are understandable to people is because of two things. Of all the leukemias that people have seen, the plasma cell disorder often ends up being the only one that they have seen. Second of all, it's easy to understand because it all comes down to this one abnormal cell, the plasma cell. This plasma cell starts to make things which cause all the problems. It makes several things which cause the problems, but it's easy to understand that the plasma cell, which has developed its own psychosis, is now making things that it shouldn't be making. It starts to make unlimited amounts of immunoglobulins against an antigen that no one can see. Now, it's good for you to make immunoglobulins, but you should make them against things that are actually attacking you. To make immunoglobulins against things that aren't attacking you is a little on the psycho part. I'm making an enormous amount of immunoglobulins against that enemy there. Can you see him? He's coming to attack me. I better make antibodies against him. In one type, mono, one type, clonal, monoclonal, M spike on the serum protein electrophoresis. Now, the plasma cell is also making osteoclast activating factor. And that osteoclast activating factor is going to the bones and sucking all the calcium out of the bones, causing hypercalcemia. Now, the bone lesions happen to be the single most common presentation of myeloma, hypercalcemia, and bone lesions because the patients complain of the bone pain. The osteoclast activating factor melts the calcium out of my bones. I have high calcium, fractured bones, and I got bone pain. People don't complain of the monoclonal spike. They get infections because what happens is all of the real antigens are coming into you. Pneumococcus is invading you, Haemophilus is invading you, viruses are invading you. But instead of that, what happens is the immune system is making the antibody against that antigen there. Pneumococcus comes into the body. Hello, I am Pneumococcus, I'm here to kill you. Don't bother me, I'm making immunoglobulin against that antigen there. What antigen? That one. Okay. And pneumococcus kills you because the entire immune system is focused on an antigen that no one can see. Also, you get fractions, portions of the immunoglobulins called a Bence-Jones protein. And the Bence-Jones protein goes into the kidney and causes renal insufficiency by being directly toxic to the kidney tubule. Fragmented parts of immunoglobulins. And because of the increased cell turnover, you get an increased uric acid. Now, these cells die and they make hyperuricemia. Why didn't we get hyperuricemia? From hemolysis. And the answer is that in hemolysis, there's no nucleus. And those nuclei is known as nucleic acids, which make the hyperuricemia. So the plasma cell is making hyperuricemia from the nucleic acids, purines and pyrimidines, inside the nucleus. The pieces of immunoglobulins, light chains, the Bence-Jones protein, osteoclast activating, sucking the calcium out of the bones, causing hypercalcemia and bone pain. The monoclonal spike against that antigen is trying to kill me. Don't you see it? I don't know. You see, the plasma cell is having paranoid schizophrenia. It doesn't pay its phone bill. It doesn't pay its electric bill. It doesn't pay its rent. Doesn't go to work. Doesn't take care of activities of daily living, but has a formal thought disorder. it's getting command hallucinations from somewhere saying, yeah, the Bulgarians are trying to attack you. Buy spy equipment. And instead of it fighting off, hello, I'm Pneumocockus. Hello, I'm Haemophilus. I'm here to kill you. What happens is it's spending all of its money fighting off enemies which are not there, to the exclusion of fighting off the infection which is there. The plasma cells, when they go above 10, 20, and 30%, start crowding out the normal marrow structures. So you become anemic. You become anemic because the marrow, instead of making red cells, is making psychotic, paranoid, schizophrenic plasma cells instead of red cells. And not only that, the plasma cells are carving out more of the bone with osteoclast activating factor. Now this is both the diagnosis and the presentation of myeloma. The immunoglobulins go to the kidney and kill the kidney by clogging up the glomeruli. The hypercalcemia goes to the tubules and kills the kidney tubules. The Bence-Jones protein and the hyperuricemia are also killing the kidney tubules. And if that wasn't bad enough, you get amyloidosis, which clogs up the last remaining nephron. So patients with myeloma are presenting with and dying with infection as well as renal failure, because the immune system is making unlimited amounts of immunoglobulin against everything except what's actually attacking it. And the kidney is getting destroyed by all the crap that's filtering out through it. Hypercalcemia, toxic to tubules. Hyperuricemia, toxic to kidney tubules. Bence-Jones proteins, toxic to kidney tubules. Immunoglobulins get clogged up in your glomeruli like my hair in a bathtub drain. Of all of these things, if you had to choose one single thing as a diagnostic test, which of these is the single most accurate diagnostic test for these? The answer is the plasma cells. You can get hypercalcemia from a lot of reasons. Hyperparathyroidism, the most common. You can get Bence-Jones protein as isolated Bence-Jones proteinuria. You can get tumoral lysis syndrome giving you hyperuricemia. You can have cancers which cause purely lytic lesions. But only one thing gives you 15 and 20 and 30% plasma cells, and that is myeloma. So therefore, as a single test, this is the single most specific test. Bone pain is the single most common presentation because this osteoclast activating factor melts your bones away. The other things are not specific just to myeloma, although Bence-Jones proteins is suggestive. What's the diagnosis? 1, 2, 3. These three things. But single one, plasma cells. Why? Because if you have an isolated monoclonal spike, but you don't have bone lesions, if you have an isolated monoclonal spike, but you don't have hyperuricemia. If you have an isolated monoclonal spike, but you don't have Bence-Jones proteins. If you have an isolated monoclonal spike, but you don't have hypercalcemia. If you have an isolated monoclonal spike of immunoglobulins against an antigen no one can see, and you don't have kidney disease, don't have anemia, don't have Bence-Jones proteins, don't have hypercalcemia, don't have increased infection, and have less than 10% plasma cells, that monoclonal gammopathy, monoclonal, one type, gamma, immunoglobulin G, pathic, evil, you may have a monoclonal spike. But if you don't have the hyperuricemia, the Bence-Jones proteins, the anemia, the infections, the kidney failure, then you're like a person who kind of thinks his neighbors are spying on him, but he still goes to work in the morning. He's just looking over his shoulder. He's still paying his electric bill and a phone bill, but he thinks the neighbors are using his electricity, but he's still paying the bill. He still pays his taxes, pays his rents, goes out to vote. He's a good citizen of the bone marrow. He just thinks people are out to get him. So he's a functional, delusional person. Now, for the bone marrow, that's called monoclonal gammopathy of unknown significance. And there's no therapy for it. Unknown significance. I didn't say no significance. 1% to 2% a year go on to myeloma. And it's not no significance because if you're the 1%, you find it very significant. 1% is only a small risk if it ain't your risk. If I tell you you got a 1% chance of dying this year, you will find this very significant. 1% and 2% is only a small risk if it isn't yours. So there are no small risks of dying if it's your risk of dying. Because you know what? If I'm the 1%, as far as I'm concerned, it's 100% because I'm the only one of me I got. It's not no significance, it's unknown. Who's going to go on? We don't know. But once you see it happen to somebody, it's significant. No treatment for monoclonal gammopathy of unknown significance. Now, for myeloma, here's something new. If you're under 70 and you're relatively healthy, it is an autologous stem cell transplant. All the way up to 70. Why? Because there's no rejection. There's no graft versus host. And stem cell are little pre-sprouted cells from your marrow that will grow up into a functioning marrow very quickly, in a matter of a week. That's like instead of growing your garden from seeds, you go to the nursery and buy the little potted plants with the little sprouts there, and you put them in the ground. They're already a little plant. It's not a fully grown plant, but it grows into a real plant shortly, as opposed to waiting for it to come to seeds, from seeds. Because if you're waiting for it to come out of nothing, during that extra week or 10 days or 2 weeks of neutropenia, 20% of you, 30% of you are going to die. And an old guy with myeloma, everybody will die. Chemotherapy, vincristine, adriamycin, dexamethasone, vincristine, adriamycin, and dexamethasone are used to prepare the marrow for the transplantation, and then you transplant. Now, if the patient is over 70 or fragile, we can't transplant. If we can't transplant, if the person is over 70 and still relatively healthy, we can use thalidomide as a substitute for chemotherapy. If the person is over 70 and very fragile, then all we do is give melphalan, which is basically acting as a palliative agent. Melphalan, which is like chlorambucil for the CLL. It's a chemotherapeutic agent that drops the number of cells. No one ever got cured from melphalan, no more than anybody ever got their hair to stop growing by shaving. It shaves down the cells. Like hydroxyurea in CML, it lowers cell count. Like chlorambucil in CLL, it lowers cell count. Melphalan in myeloma with prednisone drops the cell count. It's just to palliate old people who are very fragile, who are packed with cancer that you can't transplant. Thalidomide can be used as a substitute for the autologous stem cell transplant in older people who can't get transplanted, but they can withstand the thalidomide. Beta-2 microglobulin helps you get a sense of prognosis. Vincristine, adrian, dexamethasone are the chemotherapeutic agents to prepare you for the stem cell transplant. And remember, auto stem cell transplants up to 70. The marrow comes back fast. There's a short duration of neutropenia, and there's no rejection and no graft versus host disease. It's a huge thing. It's a tremendous advance. It's better than saying, oh, what are your choices in therapy? Oh, cremation, above-ground burial, in-ground burial, taxidermy. It's a huge advance. Imitinib for CML takes the lousy crap busulfan, which gave you pulmonary fibrosis, and eliminates busulfan, which is a dog. interferon, which made you feel like they had the flu, and makes it much better. Imatinib, a huge advance. I know what you're thinking. It's not that I don't mind the advances in therapy, but could they have been invented after I passed step 2 so I don't have to memorize as much? 6% of the general population thinks that the most important aspect of medicine is to cure disease. Only 4% of physicians think the same thing. Therefore, imatinib eradicates the disease that was otherwise fatal without the need for a transplant. Autologous stem cell transplant might cure disease that was otherwise universally fatal. Thalidomide does the same thing. Without the toxicity of chemotherapy, controls the disease like chemotherapy without the side effects. Fantastic. Socrates says the sense of wonder is the beginning of philosophy. It's wonderful. Isn't it amazing? Wow is the beginning of philosophy. And that is the truth. If you see it as wonderful, you will learn it instantly. If you see it as a burdensome pain in the ass and more data to remember, then it becomes just another thing to squeeze in, and it's painful and it doesn't stick. It becomes like an intellectual enema. You hold it for a little while, you sit down on test day, it all comes out and nothing sticks. If you see it as, isn't that wonderful? Imatinib eradicates the Philadelphia chromosome without the need for a transplant. Fantastic! Stem cell transplants. You don't go on to inexorable death and melting down and breaking down all of your bones. Fantastic! Fludarabine extends survival in CLL. Fantastic! Isn't it amazing?